Thank you to all of you for being here. Thank you to Biomedical. They're the sponsor that is supporting tonight's presentation. Biomedical has been a very good supporter of NRBS for a lot of years. They are also a real supporter of the bio and neurofeedback field. And I, urge anybody looking for equipment, or supplies to check out Biomedical. They're good people. I would ask anybody who is not a member of NRBS to check out joining us. We would appreciate it, and it allows us to do the various things that we do. I would urge all of you to check out our website and see such things as our yearly conference is scheduled for the end of October. You will be receiving things about that as the time closes in. I want to mention that we do something called the Connect Tuesdays, which is the first Tuesday of each month, 12 o'clock Eastern Time. Again, check it out on the website. We are this year devoting the meetings to talking about how we can unify and advocate for our field. I also want you to check out our podcast, which is run by Dr. Saul Rosenthal. The name of it is Healthy Brain, Happy Body. Also, if we do not get to all of your questions tonight, our presenter, Santiago, will be doing a podcast with Saul, and so that will be available, and I imagine in that podcast he'll answer things that you want to know. Okay, and Santiago's bio is on our website. I'm not going to read you all of the man's accomplishments. I mean, they are many. I view him as an ambassador for biofeedback and neurofeedback to the world. This man has worked and presented in just about, every continent except Antarctica, I think. And he just represents the field very, very, very well. We are lucky and we are happy to have him presenting. And without further ado, I will turn it over to Santiago. Thank you, sir.
Thank you, Mitch. Thank you very much. Good morning, everybody from Singapore, and good morning to some of our colleagues who are following us right now from Taiwan and Indonesia, and good afternoon and good evening for those of you in the United States and South America. I am very happy to be here one more time, and I want to thank Mitch and Angelica and RBS, Rani, and the full team Biomedical for the invitation to talk today about EEG-QEEG and neurofeedback in trauma cases. So for the next 60 minutes or so, I will be sharing my experience in EEG and QEEG analysis of trauma and some neurofeedback and some additional interventions for trauma cases. And what I will share is my experience in trauma, how I see trauma, how I work around trauma. And hopefully this will give you some suggestions as to how you can approach your interventions with your clients. Now, before I start, there's a statement that a lady gave to me here this past week. I have been doing some QEGs, and I'm seeing this young 35-year-old woman here in Singapore. She's local Singaporean, and I see some patterns in the EEG. I ask her, do you have any trauma history? To which she replies, I'm Asian. So that statement really stuck with me because it talks to how culture will weigh heavily in somebody's trauma response. And the more I spend time here around Southeast Asia and the more friends I make locally in every country, the more I understand how culture here and everywhere in the world where I have the privilege to travel really shapes trauma and how that should be factored in your interventions. Now, without further ado, some of the learning components for today, the learning points is I'm going to talk about four um, components of the trauma response that I see in every client and that your clients, your trauma clients, your PTSD clients will likely present. Some EEG biomarkers that have been identified. We'll talk about the QEEG itself, what the QEEG shows, some neuroanatomy and symptoms, and neurofeedback and other interventions. Well, that's what we have for today. Now, I always, when I start talking about trauma, I like to start the presentation with these four components. I think they're important to identify and they're important to understand because they're present in people with trauma. Normally, in my experience, for most people, they present with all four. However, one or two will be more salient at one time or another, meaning that many clients will present with hyperarousal as the salient presentation, and that's what drives their symptoms and their behaviors. Some other people will be more constricted. They will suppress. They will not speak. They will not talk about it. And that has a different behavioral presentation. And that's something that we can also pick up in the EEG. Dissociation is very common. And these are probably, at least in my experience, these are the toughest clients to work with. Sometimes it's very difficult to break the dissociation, to reset the brain to a previous baseline point because these clients heavily dissociate. Sometimes they don't understand the neurofeedback quite efficiently. So I will give some suggestions as to how you can work around that and circumvent the dissociation to get the brain to become healthier and for the individual to function more optimally. And last but not least, we'll have freezing and helplessness. This is quite common too. And the way it's manifested verbally by many clients, excuse me, is that they will tell me, this is, you're my last hope. This is my last resource, leading the neurofeedback, because I'm convinced that nothing will help me. I've tried everything that I can possibly think of. I've tried acupuncture. I've tried medication. I've tried psychotherapy. I've tried hypnosis. Nothing has really helped me. To this point, where what I tell the individual after we're looking at the EEG, I record the EEG and I start doing the interpretation. I will tell them, I don't think that it is necessarily that none of these things have worked for you. Let's take a look at your brain, and we can see that your brain has these patterns, and your brain is not flexible enough, is not ready to get the help that it needs. When I frame it that way, it really changes the outlook for the individual. It provides them with the hope that sometimes they so desperately need to get help. So, as we look at the brain and as we look at the EEG and the QEG, we can understand how trauma manifests individually for this person and how we can individually and personally work on the intervention. Now, there are symptoms that are present. Sometimes they're overt. You know it right away. The client has sweaty, clammy hands. Sometimes they're a little uptight. Sometimes they don't talk to you. They look anxious outwardly, and sometimes the behaviors are more covert. You wouldn't know by looking at the client and by initially interacting with them that they're anxious, that they're hypervigilant. It's really important to understand how this plays out. And normally in my assessment, what I do is the QEG, the EEG-QEG, and then I'll do a psychophysiological stress profile, because a lot of the symptomatology from the hyperarousal, from the hypervigilant, you can pick up by looking at the psychophysiological variables. The heart rate variability, the galvanic skin response, the peripheral temperature, the muscle tension, all of this, you can pick it up. And you can relate that to the QEG. And what I do is I record a baseline EEG 10 minutes with the eyes closed, 10 minutes with the eyes open, sometimes under a task. And then I will record the psychophysiological stress profile while recording the EEG at the same time. I want to see what happens to the person's brain as they're under duress, under distress. Okay. And you will see there's specific changes and shifts in the patterns. So this becomes more useful because the more data you can accrue, the more information you have, which means the better your intervention planning will be. Now, clients who suppress. I think that there's a lot to be said for EEG and neurofeedback. Um, this works especially well in teenagers. When a teenager comes for brain map, they normally don't say hi to me. They normally are angry that they're seeing another shrink, another person who's going to look at their brain. They're thinking they're coming to psychotherapy and they have to talk about their problems with this stranger who I don't know and I don't really care about. And the moment I tell them what we're gonna do, I take out the cap or I put on the helmet, the eye medicine helmet, it sparks their interest. And now their demeanor changes. They're more open, at least to the experience of the assessment. And as I'm looking at the EEG patterns and I'm feeding the info back to them, I can see that they become more interested. They're more open. They're less guarded. Not all of them, of course, and it takes, over the course of sessions, you start building more robust rapport with them, but it really helps. And I think that EEG, QEEG, and neurofeedback, among other interventions, are quite valuable for the clients who are suppressing their emotions. They don't want to be re-traumatized. They have been ridiculed. They have been misunderstood, and they just are done. They don't want to talk. Therefore, giving them feedback in a way in which they feel understood and not judged is key here. A common response that I get from teenagers and individuals suppressing their emotions, and mostly from teenagers, is when we're done with the assessment, they would turn around, look at their parent and at their parents and say things like, "I told you I'm not crazy. I told you I'm not making this up." And tears, running down their face, and the parents become more open as well and more understanding. The relatives, the friends, the family, their inner circle becomes more understanding and empathetic, uh, maybe compassionate to their situation. Dissociation has clear patterns. We'll discuss this as we go along into the presentation, but this is a very important one to identify and understand because many times the reason I see psychotherapy falling short or maybe failing for these individuals is, well, because they're dissociated. They don't have the brain power and the brain structure to understand what the skill set that the therapy is trying to teach them. These individuals are, in my experience, the group that complains the most about psychotherapy not being useful for them. They didn't feel any benefits from it, or they felt that it benefited them, they plateaued, and after some point, it wasn't working for them anymore. And then again, I will explain to them, this is what your brain looks like. This is the reason why psychotherapy is not being more efficient for you. Normally, after the course of a few sessions of neurofeedback, once I feel and they tell me they feel better and better self-regulated, I suggest that they go back to therapy, and about 80% of them will go back to it and further benefit from it. Some 20% say, I'm good. I think I can work with my life now that I've done the brain training. And they do fairly well. So you will see behaviors like flat affected, lack of empathy, disconnection from the world. I saw yesterday, the day before yesterday, saw a lady here and she said, I'm really concerned because people tell me that I'm really distant, that I'm rude, that I'm obnoxious, and I don't feel that I am that way. So when we were looking at the brainwave patterns, I was able to relate to her why people will feel she's that way. And she goes, that aha moment when she goes, I get it. And then helplessness, of course, there's nothing anybody can do for me. I've tried everything, and so on and so forth. When we do the EEG, we can provide these individuals with hope. And if you know anything about my work, because I talk about it constantly, is I am not about diagnostics and labels. I talk about patterns, I talk about tendencies, and I will explain the EEG, telling them this is how it relates to you right now. This is not your brain forever. It does not have to be your brain forever. We can optimize this, we can stabilize this. And that gives the person hope. They can start seeing the light at the end of the tunnel, if you will. So with that in mind, and having said that, let's talk about some of the biomarkers that I identify. Maybe some of you have identified already. I think this can give you a new light on how to work with it. We'll talk about lambda waves, excessive beta, specifically beta spindles, new brain waves, the T6 alpha, the high peak thin orthotic alpha marker at T6, and some other patterns that we don't commonly associate with trauma, but can be part or a byproduct of the trauma response. Lambda waves are very common, and those of us who have trained under the one and only Jay Gonkelman are quite well trained to identify them. But I notice when I supervise individuals who were new to EEG and QEG, when I point the lambda waves to them, they tell me, "Oh, I've never heard about them before." So it's a good opportunity to educate them on what they mean. Um, what I've seen in terms of lambda waves is that number one, they correspond to eye fixation. So some percentage of the individuals who are fixing their eyes on a wall when we're doing the EEG will start producing these lambda waves. But in trauma clients, I have noticed that it's highly correlated to hypervigilance. And many of these individuals will meet the criteria, the diagnostic criteria for PTSD. So lambda waves are more severe in my experience, the way I've experienced this clinically. It's a more severe manifestation of trauma. And the hypervigilance is extreme. The anxiety is quite high. The behavior presentation is quite overt. The individual looks very anxious. They will bite their nails. They will pull their hair. There's a lot of behavioral components that go around this. And therefore, identifying them is very important because when I identify lambda waves, I want to further assess for the possibility of PTSD being present. We go from a highly activated trauma response to possibly having PTSD, or maybe chronic PTSD. And I work with a rehab facility out of Chiang Mai, Thailand, and they send me EEGs, and I fly there every now and then to do EEG assessments with them. And in the addictive population, we see a lot of lambda waves. These populations have a higher prevalence of lambda waves. They're more severely charged, more severely traumatized. And the fact that they're using and abusing doesn't really help the situation. Now, the lambda waves will look like alpha in the QEEG. Normally, you have the alpha peak in the occipital region. It's an O1, O2 phenomena. And you have to understand that's the lambda. It's usually fast in the range of maybe 11 to 12 hertz. So that also tells you that the emotional systems are engaged. The occipital region is part of the affective systems, the affective networks. And you have visual hypervigilance. You're scanning the environment for looking for danger 24/7, essentially. And you're more prone to believing that something bad could happen at any time. That speaks to the severity of the trauma itself. If there's more than one trauma, at least one traumatic event in the person's life, more than one, which is often the case, it will speak to the severity of the trauma. Now, we cannot go back in time and change what happened. So what we focus on is changing the response to it and suppressing the fast lambda, the fast alpha, and in this case, the fast beta for this individual beta and high beta becomes increasingly important, becomes a key component to the intervention. And I also like to use Loretta because Loretta helps me confirm on the generator, and it helps me see if there are additional neuroanatomical regions that can be impacted by this, but are not directly correlated to the trauma per the subjective experience and report of the client and those around them. So for this individual, the T5 region, the P3 region will also be dysregulated. And it normally means that these individuals, in addition to the trauma, the PTSD, are going to start noticing problems with short-term memory. And if nothing is done about it, later down the road, they're going to have experience trouble with long-term memory. So I will tell them, are you forgetting things? Are you noticing that you're forgetting, apparently trivial things like where are my car keys? Where did I put my cell phone? Sometimes the individual will tell me, I'm speaking on the phone with somebody and I'm freaking out because I cannot find my phone. I'm looking for the phone that I'm using to speak to somebody. I'm wearing my glasses and I'm freaking out. I'm panicking because I cannot find my glasses. So these are the types of memory issues and the anxiety that goes parallel to it that you notice in people with hypervigilance. Their memory, and their productivity start dwindling. And that's also cause for concern. Now, normally, because it's not the most salient presentation, people will take it for granted or ignore it until it really becomes a big problem. Now, next, we'll have the beta spindles. And with beta spindles, the first thing that I want to say is that we need to ensure that the pattern is not because of a medication effect. So usually benzos and other types of medication will give you a global diffuse beta spindle presentation. So you will see it essentially on all 21 channels or more, depending on how many channels you record with your amplifier. Now, when it isn't a medication effect, because the individual will say, I don't take any medication, then we know it's probably likely to being the byproduct of a traumatic event, the part of the trauma response. But it also corresponds to a neuroinflammation pattern. So when I talk about neuroinflammation, it's inflammation in the brain, but it's inflammation in the body. And normally what I do, I see that Mike Peters is around. Hi, Mike. What I normally do, and he will understand this, and some of you who work in tandem with doctors will understand it, is that now we have to look for inflammatory markers in the bloodstream. Why is it important to do it? Well, just like doing an EEG talks about your personal experience, people will present with different and unique inflammation markers in their bloodstream, cytokines and whatnot, right? So we all have some degree of neuroinflammation. Some of it is functional, some of it is more detrimental to our well-being. But the important thing is that to understand that just like two brains are not alike, not two metabolic patterns are alike. They're similar, but my inflammation neuromarkers will be different from those of Mitch and Angelica and everybody in the room. So doing that, it's very important because we have a roadmap. We have a guideline into how we can work from the individual to the individual and for the individual. Okay, we should not be working, at least primarily, with a one-size-fits-all approach. And it's also important to understand how this regulates the metabolism and how this in turn creates inflammation in the brain. Because one of the elements that you see here is that you have blood-brain barrier permeability. Things that are not supposed to go into the brain will get into the brain because the tight junctions that protect your brain will open up and they will, welcome anything that's not supposed to be there. So once you have the inflammation going on, the next thing you have to decide is, will neurofeedback be the weapon of choice here? Will it be the first option? Sometimes it isn't, because sometimes when you start the neurofeedback, the client will abreact. As you try to down train and inhibit the fast patterns, you get the opposite response. The symptomatology gets worse. And that may mean that the very first thing you need to do is dampen the inflammation. Once you say inflammation, you need to dampen it. So you essentially have to switch the bad glia cells into good glia cells and get more of those so that your brain can function properly. That means that many times when I see this pattern, the first thing I will go and tell the client is, look, you're a candidate for neurofeedback. However, I'm not going to start working with you because I have a feeling that I'm going to be overwhelming your brain. And this is like somebody goes to the gym and they're physically not adept, and the trainer starts putting them on heavy weight and doing cardio work that is not functional for them. So doing the neurofeedback might not be the first choice. So what I do is I would refer to somebody like Mike. I work here in Singapore with a functional doctor and a functional nutritionist, and I will say, tell them that you saw me and tell them that I refer you to them. And based on the EEG info that I provide for them, they will, and also on the interview that they have with the client, they will prescribe an assessment. And this assessment includes food insensitivities, food allergies, inflammatory neuromarkers. There's a test called the SIBO, SIBO, in which you blow into a tube for like 4 hours. It's very long, very unnerving, but very important, because the SIBO detects your gut microbiome. Oops, I think you lost my screen, guys. Can you see my screen? I lost my presentation. Can you still see my presentation?
Yes, we can see it.
Oh, I cannot. Oh, sorry. Okay, here we go. Apologies. So the SIBO will detect the structure of your gut microbiome. It looks for Helicobacter pylori. So it looks for bacteria that is not good for you. And that's what I will. When I see the high beta pattern, I need to decide, can I start with neurofeedback? Maybe not a good idea. So we'll explore what other options we have. But it's very highly hypervigilant, highly hyperexcitable. And in addition, these individuals will have hypersensitivity to sensory and perceptual stimuli, noise, physical touch, light. So these are individuals that will avoid the shopping mall because it's very crowded. They won't go to a movie theater because it's too loud. They won't go to an airport because there's lights and sound and it's very overwhelming. So these individuals do struggle from a sensory perspective as well. And as you can see in the QEG, now the pattern shows up. You can see the high amplitude beta, the high amplitude high beta. Now, sometimes the beta can be compensatory. This is important to understand. What I look for in the EEG is how repetitious the pattern is. If I see that there's 13 to 21 low beta, 12 to 15 low beta, but it is quite repetitious, I'm going to understand that that is not a normal, healthy pattern. Because the more it repeats itself, the more intense it will be. And you can see now using this is a Laplacian montage, the global common average montage. It gives you a fairly accurate, or rather a very accurate distribution. Now, speaking of other areas involved, once you see the high beta and also the mu, with the mu, what you see is that you now have insular involvement. So I've seen this quite frequently in clients who present with the fast beta, the beta spindles, and also the mu, more commonly in mu. Now, what do I see with mu? It's a problem with the mirror nervous system. It can be a positive dissociation, as I like to call it, meaning it's the type of dissociation, for lack of a better term, that allows you to get into the zone. Mu can be present in individuals with peak performance. And they're not necessarily in this spectrum, and they're not necessarily traumatized. I've picked it up in corporates. I have picked it up in athletes. I have picked it up in combat and elite forces, surgeons. And it's an ability to get into this trance-like state and perform in the midst of all the stressful things that are going around you. So if you're a surgeon, are you gonna do a surgery, brain surgery for the next 8 hours or so? This works in your favor. Now, I have also seen you in trauma-related dissociation. So I look for autism, I look for dissociation, positive dissociation, but I have seen it in negative dissociation. Now, what is the difference that I've seen? The people who are peak performance, when they have the mu, their insula normally doesn't light up. The left and the right insula. However, in people who have mu and they also have trauma history, the insula lights up as also a generator. And in the insula, now we have additional behavioral presentation. We can see depression, we can see anxiety, we can see agitated depression, we can see bipolar, we can see paranoia, we can see dissociation, we can see anger gating or impulse control problems. So these individuals, we have two particular types of presentation. Ones, they lash out and they explode and they're very aggressive, or they suppress. The individuals who suppress normally have left and right insula activation. So these individuals go into their own world. They dissociate, but they don't necessarily manifest it outwardly, verbally, physically, or both. They go inside. I did a QEEG for a 15-year-old girl last night with trauma response, and she had the mu pattern, she had the insula activation. And when I told the parents, what does she do? Does she get aggressive with her siblings when they're bugging her, or does she just go into her own world? And they said she just goes into her own world and she looks depressed. So that's the kind of pattern that you will see. And you will also pick it up in the EEG, normally F7T3, F4, F8T4, or F77, F8T8 will give you sometimes transients. And the transients indicate that the insula doesn't have the off switch. So what behaviorally that indicates is that this person normally doesn't have an off switch. The reaction is quite instinctive. It's a survival mechanism. It's not the right survival mechanism. It can get you into a lot of trouble, but it's just how it manifests itself. Now, if you also notice, there's the high beta, it's rearing its head here. So you can now go back and look for the pattern in the EEG. So you can see right here we have the mu, right here we have the alpha, but you can see the beta bursting before that. So what does that mean? The moment you see beta before the mu, it means that you have a hypervigilant individual whose coping mechanism is dissociation. That's how they learn to cope, by dissociating. And the more it happens, and if there's re-traumatization, the more they're going to dissociate. Now we need to understand that what we need to figure out, rather than understand, we need to figure out how are we going to break the pattern, because this is very difficult to train. And then we also have the T6 alpha, that infamous T6 crethoric thin alpha over at P8 T6. That's a neuromarker that's been published. There's papers that talk about it. There's a paper called the electrical aftermath. If you email me, I'll share my email after we're done. It's called The Electrical Aftermath, and it's a paper that is published that talks about that identifies the T6 alpha marker as a trauma PTSD marker. What is the specific presentation? It's a social affective disrupt. So it disrupts how you relate to people, how you relate and interact with people. Now, it could also be a marker for intergenerational trauma. This EEG is from a colleague of mine. She's from Vienna, Austria. And she was interested in learning more about EEG so she could refer clients for EEG. And when we did it, we found that she had the marker. And you can see the P4T6, P4P8 marker there. And when I asked her, do you have trauma history? She said, not that I have experienced myself, but I'll tell you this. My grandmother is a Holocaust survivor. And there's been studies in which this has been present. They've done studies of EEG and also inflammation, actually, for the grandkids and great grandkids of Holocaust survivors, particularly in the Netherlands. And what they have found is that they have inherited the patterns for trauma and autoimmunity that were inherited from their surviving grandparents because of being in the concentration camps, and also because of the famish that they underwent when the Nazis invaded the Netherlands, and they were imprisoned, and there was a shortage of food. So this can speak of intergenerational trauma. If the person is telling me, I don't I have not experienced trauma myself, and I give them the benefit of the doubt, I will say, well, is there a family history? Sometimes they can recall it, sometimes they don't know. Now, the important thing here is not to know what happened. The important thing here is that we know that it's there, and it can speak to socioaffective issues. So how does it manifest? The person has social anxiety. The person will experience difficulties socializing with people. They cannot identify facial expressions. They fail to identify when somebody's angry with them, when somebody's smiling because they're happy. They fail to understand sarcasm and humor. So sometimes the people around them will joke, and they don't understand the substance to it. So there's a big component. Now, when I see the peak at P4, the number one thing I'm going to ask that individual is, do you have difficulties trusting people? Because that's a pattern that I see when people have had trauma experiences. They will develop a huge mistrust for others. And I ask them, do you have difficulties trusting people? That they tell me, I don't trust anybody. The next thing I ask them is, in a social setting, you are in a cocktail, you're in having lunch with friends, you're in a gathering with people, a barbecue. If given the option, would you prefer to be alone? And they say, yes, I don't want to be around people. I'd prefer to be alone. If given the option, I would prefer to be alone. The more I stay in those social settings, the more anxious I'm going to feel, the more inadequate I'm going to feel. And a key thing is that they will say, I will have to really refrain myself from being rude and being distant. It's hard for me to be social around these situations. And I will explain to them, well, that makes perfect sense, because look at this brainwave here called the alpha frequency. This is a region of the brain where you interact socially with others. So that area of the brain is not really computing the numbers very well for you. That's why you feel anxious in social situations. Some people tell me, I want to be more social. I want to feel more. As a matter of fact, I did an EEG for a Canadian veteran in the Chiang Mai clinic, and he had this marker. The one thing he said that was his priority was to feel again. He says, I want to feel again. I don't feel sadness. I don't feel joy. I don't feel anger. I don't feel anything. I want to feel again. So it just shows you how can we can revamp the patterns for these individuals. Now, what's important to also understand is the orienting response, which means that inevitably a large percentage of these clients are going to orient to what traumatizes them in the first place. It will come across as if they were addicted to it. They look for the trauma and they look to sort of become re-traumatized. And again, it's just a pattern. Well, understanding the EEG gives us the opportunity to tell them. And of course, we need to work from a physiological and cognitive perspective. The question that I often get asked by clients is, should I quit therapy and do neurofeedback? I will say, no. You're going to do neurofeedback and biofeedback and whatever other form of intervention we can prescribe for you, plus your therapy. The neurofeedback, the way I explain it to the client is the neurofeedback is going to give you the substance. It's going to make it easier for you to cope. It's going to make it easier for your brain to learn. The therapy will give you the skill that you need to implement day in and day out. And the reason why you're not able to implement that skill successfully at this point is because your brain is not able, it's not ready to do so. Let's do neurofeedback. Let's do photobiomodulation. Let's do biofeedback. Let's do EMDR. Let's do brain spotting and get your brain ready to do it. So once we start refurbishing the neuroplasticity, now the client, it's more and more ready to do so. And to do that, we can look at different things: the heart rate variability, the skin conductance, the temperature, the respiration rate, and so on and so forth. Now, I'm going to go back and say, if you as a clinician are not doing or involved in any metabolic work, I suggest that you do so. And Mike Pierce, who's part of the audience, is a really good person, so you can look him up. And if it is okay, Mitch and Angelica, if Mike can provide his email address in the chat room, that would be delightful, because he is one of the go-to individuals for this. Highly knowledgeable, and it would benefit you to understand how metabolism and the brain interact and how the metabolic profiles of individuals with trauma are highly dysregulated. So how you can do the top-down approach from the brain and the bottom-up approach from the body. So one of the intervention modalities that I use, we'll get to the neurofeedback shortly, especially to break the dissociation, is heart rate variability. And I'm going to show you why. This is a case study of a client who worked in construction. And one day he witnessed an accident at his construction site. It was a co-worker who was a victim of this accident, and the co-worker survived, but he was severely injured. And he witnessed this. So he developed this trauma response, not by being the direct recipient of the event, but by witnessing that. And his main presentation is new brainwaves, which mean he was highly dissociative. Okay, this dissociation was the main thing for him. He said, I go into a trance. I'm with my wife, and I go into a trance. I'm at work, sharing a few beers with my coworkers, and I go into a trance. I cannot socialize anymore. And I used the Mitsar at that time to record his EEG and his EKG at the same time. So here at C3, you can see the mu response. But the main point is that when you see the break into the desynchronization of the mu is when we started doing the heart rate variability. So you can see the mu here at baseline, and then here where the green arrow points is when we started doing the heart rate variability, and you can start breaking the dissociation. And I've done recordings time and again, and it works very well with about 90% of the individuals. Mind you, and this is important, this is only a 5-minute session. Now, I'm not saying that it only takes one session of 5 minutes of HRD, the biofeedback, to work, but If you can record the EEG at the same time you're doing the work, you can now objectively show that it works. And I don't do client work anymore. I don't work with clients anymore. But when I did, the number one thing that I did with clients who had new dissociation because of trauma was the heart rate variability first. And then I would follow up with some neurofeedback. Now, let's talk about another case and do some protocols that I've used that may be of importance to you. This is a client that I had a couple of years ago here in Singapore, with who came complaining of depression, developmental trauma, heavy developmental trauma. His salient marker was T4 elevated alpha and lambda waves. So here's the alpha at T4, quite a synchronous pattern. And in the occipital lobes, you can see the lambda waves. So highly hypervigilant, highly reactive, highly aggressive, a very, very extremely angry individual. Now, this is after 13 sessions, he says, can we do a control EEG? I'm feeling better. So this is baseline. This is the eyes open recording, by the way. And this is after 13 sessions of neurofeedback. CZ to T4, active electrode at CZ, reference electrode at T4, and then the ground at A1. And the protocol that I did was suppressing 1 to 4 for the delta, 4 to 8 for the theta, 8 to 12 for the alpha, 20 to 30, and I rewarded 12 to 15 hertz. This is the QEEG before and after 13 sessions. And you can see there's a noticeable reduction in the alpha. And the one thing he said is, I'm not that angry anymore. And the wife who would come to the sessions with him says, thank you, because you're not only saving him, you're saving our marriage. I was about ready to divorce him because I could not deal with his outbursts anymore. So we identified the pattern, we train the area, we're patient, we work hard, and hopefully it pays off. This is a 14-year-old who was adopted by an American family. They live here in Singapore. He was adopted in a Russian orphanage. So he was born in Russia, and he was adopted when he was 4 years of age. So at birth, he was given away into the orphanage. And for the first 4 years, he had no paternal or maternal contact. Okay. And it is my understanding that he had not 3 meals a day available or 3 meals a day available, and so on and so forth. So what was the presentation? FC elevated theta, which behaviorally manifested as heavy suicidal ideation, mu waves, and parietal P4 alpha. Highly disconnected from proper social interactions. Highly aggressive. And an OCD presentation. He could not eat chips or anything with his bare hands. It would induce a sensation of nausea and vomiting, and he could not watch other people eat with their bare hands. We did 80 sessions in total with CZ to T6, so active electrode CZ, reference electrode T6, FZ, linked gears, and F3, F4. The CZ to T6 to target the trauma, the FZ to target the cognitive inflexibility and the rumination and the OCD, and the F3 to F4 to suppress the mu. So when I see mu at C3, C4, I will go back to F3 and F4 and do suppression only. I inhibit everything. I don't reward anything in particular to suppress the mu, work on the mirror neuron system, and it works very well. This is him with the mu and the alpha, and this is his spectra at baseline, and this is his spectra after 60 sessions. This is his anterior cingulate at baseline, and this is the anterior cingulate after 60 sessions. So It works, but it takes time. What I run into them recently at a shopping center. He's doing very well, getting straight A's, socializing, no more reports of problematic behavior from the teachers. He hated me for the first 40 sessions of the neurofeedback. I don't want to be here. I don't know what I'm doing here. And now he says hi to me. Um, After the 50 session mark, he started coming with gifts. He would bring chocolate or croissants for me and my wife. So he says, "Yep, please send this to your wife." My wife has never met him, but he became more social, more socially aware, more adept. So as you can see, that's what we can do. Now, I know that I'm walking the tightrope with time as I always do. So I'll talk about um, neuroinflammation for a moment. Another intervention that I now heavily use for trauma, especially when it comes to dampening the inflammation, is photobiomodulation. And I work closely with the folks at Medicine in Korea. Um, and this is just to show how trauma itself can increase inflammation in the brain. It's not brain injury, it's emotional trauma. This is somebody who was at MCI at 50% already. This is a person who's, I think, 60 years of age. And after undergoing a traumatic experience, his AMCI jumped to 64%. So trauma is no joke. It can increase inflammatory markers and it will increase your likelihood for neurodegeneration. So there's a link here between trauma, PTSD, and neurodegeneration if we don't do anything about it. This is what his brain looks like. The absolute and relative topo maps. Brain is on fire. This is baseline, and this is after the traumatic event. Very active anterior cingulate. And look at the connectivity. It's hyper connected, hyper vigilant. But the AMCI jumped. So now we can do photobiomodulation. If you want this document, this is from Dr. Debbie Kim out of Los Angeles. She works with the eye medicine and photobiomodulation, and these are some protocols that she has designed. So if you want this document, I'm happy to share it because it's public domain at this point. And you can directly contact her if you want to know more about her work. And this is photobiomodulation left from an individual with PTSD. This is from Manuel Halter, Dr. Manuel Halter out of Tampa, Florida. Some research with veterans. This is before and this is after photobiomodulation, also using a specific protocol.
Another interesting
This is before. This is the analysis of underactive and overactive areas, and this is about 2 weeks intervention. 2 weeks intervention, 3 sessions per week for about 30 minutes per day. If you're not doing photobiomodulation, I strongly suggest that you do if I can give you only one reason, is dampen the inflammation. Once you dampen the inflammation, your client responds better to neurofeedback. They respond better to therapy. They respond better to
the first case.
to anything. All right. At this point, I want to say thank you, everyone. I know I probably overshot my landing a little bit. Oh, no, we're good. So I can stay, hang up for questions a little bit.
Yeah, we actually, first of all, thank you. That was very good. We appreciate your knowledge. There are a couple things. One person asked, which is the best montage to see the beta spindles, and in which region?
Good question. Just before I answer, I'm typing my email into the chat so that if anybody wants any papers or any of the info that I shared, they can do. Now, for montage, I normally use the Laplacian, the global average in WinEEG, but I also suggest that you look at bipolar, either transverse or sorry, the word escapes me right now. The 2 types of bipolar, transverse, double banana. I normally use more the common average. It gives me a very good global view and understanding of the beta spindles. If you want confirmation on specific generators, then you may want to look at it in a bipolar montage. And then Loretta is the tiebreaker, in my opinion. If you want to have specific location, then Loretta will do that. What you have to be mindful of is that many times people only rely on the maps. You have to look at the EEG. What I mean is people will send me the QEG and they tell me, I have a lot of high beta. I tell them, please send me the EEG. And when I look at the EEG, it's not really high beta, it's just EMG muscle tension. So rule out the muscle tension, rule out any medication effect. And again, in my experience, the global average montage plus a bipolar is a good option.
Thank you. And what about looking at the alpha peak as a trauma marker?
Don't understand exactly what they want to do.
Well, I think what I think it is that in some circles, if you look at the amount of the alpha peak from the eyes open to the eyes closed, if it's less than a 50% increase in the amplitude, some folks would say that's a potential trauma mark.
I would partially agree to that. Why I will add to that, and the reason why I partially agree to that is because sometimes the amplitude cannot be that high and there still be a trauma response. Now, the marker itself, the amplitude itself might not be strictly related to it. But what I invariably notice is that this peak will stand out in about 80% of the cases. It's more noticeable in the eyes closed condition. In about 20 to maybe 25 of the cases, I will see it in both the eyes open and the eyes closed. Now, what the particular morphology is very high in amplitude and is quite thin. So it gives you that kurtosis, which is the lack of resilience, lack of flexibility. And it normally stands out, meaning it's really high, is right there. You may pick up alpha in other areas of the brain where you don't want to see it, but that peak particularly stands out. So if you see it, you need to take it with a grain of salt, and that is, you need to ask. The fact that it's there does not necessarily mean that the client is manifesting trauma. They may have had a history and they don't remember it, or it could be related to social anxiety. It could be related to what we formerly called Asperger's, pathological attachment. So it could mean other things as well. But if the client has experienced trauma and it is there, then the correlation is undeniable.
And then,
Santiago?
what about the use of alpha theta for trauma? That's the person said that's been around for 35 years or so, and it's used a lot. What about that versus what you just talked about?
Well, that's a very good question, and thank you for bringing that up. I think alpha theta is extremely useful. I, however, only will implement it, or I implemented it when I was doing clinical work after after the client was able to self-regulate. So, if you have a client with beta spindles, that is not the result, that are not the result of medication and rather hypervigilance or inflammation, they are not going to respond well to alpha theta. They're not going to be able to go into the state because they're hypervigilant. So what you do is you first suppress the fast beta as much as you can. You teach them temperature biofeedback. You teach them Harry biofeedback. And then once you see from the EEG and from the client report and your own clinical observations that the client is ready for it, that you can implement it. I implemented it with back maybe 10 years ago. I used to implement it with sexual abuse cases, mostly teenage males who had been victims of sexual abuse by relatives for the most part. And when I was implementing the alpha theta, many of them reported that they were dreaming of killing their relative. And I would tell them, well, let's just take a look at that closely. that, but it normally means that they're transforming or giving new meaning to the trauma. None of them went on to commit murder, but they could resignify the trauma. So is alpha theta usable? Yes. Do I use it? Yes. But only if and only if you can help self-regulate. So a lot of these protocols work on the trauma response, but have a high degree of self-regulation value, which can then allow you to implement psychotherapy or EMDR or brain spotting or other interventions that can add to that toolbox of options that you have.
And then the last one that's here, maybe you know what this means. I'm not sure. It says with IAPF, the individual alpha peak frequency, it says the peak is on when it hurts.
Oh, I'm guessing if they're referring to the biomarker, the neuromarker that is the alpha T6, it normally is fast. I've seen it. I've seen it in the 11 to 12 hertz range, maybe sometimes a little faster. Sometimes you will also see beta, high beta there. Not always, but you always see it there. But have I seen it in the slower range? Thin, high amplitude cathodic? Yeah. I've seen it with 9 hertz, 8 hertz. Anytime I see it, I assume there's trauma, but I cannot know it unless I confirm with the client. So for the most part, at least in my experience, it's fast, 11 to 12 hertz. In some cases, it will be slow. And as for the microvolts, it really, the amplitude changes from individual to individual. But you can see it, if you see it in the EEG, the amplitude is quite high, is very synchronous. And once you put it into the QEEG, you can see it there.
I'm going to end things right now and say, and thank you, sir, and that I urge people to tune in to the podcast. I'm sure questions will be answered, there. And again, thanks a lot. This is very good. And all of you who were here today, we appreciated your attendance. So thanks a lot, folks.